Hello, friends. I'm Dr. Harvinder Singh, and this is our podcast number 2. If you have not watched our first podcast yet, I will highly recommend. Please watch it. It was on comparing mood stabilizers, and this podcast will focus on genetics testing in psychiatry. Very hot topic right now in psychiatry. We all know recently FDA released a statement of caution, and last week, few days ago, they released a statement or a warning statement for genomic labs who are claiming to predict the response of specific antidepressants. But I personally, in my practice, don't go to genetic testing as first line, but I still feel they carry some important role in specific population. Mostly, I get my patients bringing their results done by other providers and asking for recommendations. I believe that genetic testing can be a good augmentation agent to your clinical decision making, but not in all patients. Only in specific patients, especially as we know treatment resistant disorders like major depression, bipolar disorder, and many others. So, this podcast number 2 will focus on MTHFR gene, which we know encodes for MTHFR enzyme. So, primarily folate metabolism and antidepressant response. We also have a video podcast number 3 releasing today, which is mostly or only for our course subscribers. And that chapter will focus on gene SCL6A4, which we know encodes for serotonin transporter. I will briefly summarize the topics that we will discuss in these two podcasts, and then we'll go into discussion mode. Now, this podcast that you will be listening to on MTHFR will focus on first, I will describe the basic folate metabolism and how that relates to depression or non response to antidepressants. Number one, we'll talk about various MTHFR gene polymorphisms, and we'll go into high risk populations where you should be very cautious of this polymorphism happening or having low folate levels. Then we'll go into specific lab work that you can order, which is not genetic testing, but a lab work that you can order in this population. And then in the end, I will talk about the treatment, which is L-Methylfolate. We'll talk about dosing, durations, and in the next podcast, which is on SCL6A4, I will talk about basic polymorphisms, what genetic testing will tell us if you order it, and how you can use that information. We'll talk about how this polymorphism differs in races, Caucasians, and Asians. We'll talk about how this polymorphism can affect the efficacy of SSRIs and side effect potential from SSRIs. And we'll also talk about non-SSRI options based on the polymorphism of SCL6A4. So without wasting any time, let's begin our podcast on MTHFR first. Okay, friends, let's begin our first chapter in this section of genetic testing in psychiatry. And the topic is MTHFR and L-Methylfolate. Before we go into L-Methylfolate, let's spend some time understanding MTHFR. MTHFR gene encodes for MTHFR enzyme, and MTHFR stands for methylene tetrahydrofolate reductase. This is one of the important rate-limiting step or enzyme in folate metabolism. Folate metabolism is highly complex cycle which plays an important role in depression or response to depression treatment, antidepressants. Let me spend some time explaining this folate cycle. I will just focus on important steps in this cycle. So the cycle begins with dihydrofolate conversion to tetrahydrofolate via this enzyme called dihydrofolate reductase, DHFR, mentioned here in red. And the cycle moves forward. Many enzymes are involved, but the last step in this process is conversion of 5,10-methylene tetrahydrofolate to 5-methylene tetrahydrofolate, and the enzyme responsible is MTHFR that we just talked about. And I will talk about this very soon, but let me finish this whole cycle. And just to summarize why this is important with depression. So 5-MTHF is what L-Methylfolate contains, or this is what L-Methylfolate is. So 5-MTHF converts BH2, which is dihydrobiopterin, to BH4, which is tetrahydrobiopterin. And BH4 is responsible for activation of tryptophan hydroxylase, and tryptophan hydroxylase is responsible for synthesis of monoamines like serotonin, norepinephrine, or dopamine. This is a diagram made by me. As you can see, tryptophan is converted to 5-hydroxytryptophan by tryptophan hydroxylase, one of the initial and important step in formation of monoamine. The process moves forward and serotonin is formed, and we know what happens after that. So this is a basic connection between folate cycle and synthesis of monoamine. You see that 5-MTHF is circled and MTHFR is circled. These are the important topic that we will be talking about in this section, in this chapter. Before we go into MTHFR, I just want to briefly say one thing, that 5-MTHF also is interacting with another cycles like a methionine cycle. It is responsible for conversion of methionine to homocysteine. I'm sorry, I take it back. It's responsible for conversion of homocysteine to methionine. And this is very important, and I will talk about that at the end of this lecture. Now, let's continue and talk about factors that can result if any of these enzymes or substrates or products are affected. For example, if 5-MTHF is low, it will affect low serotonin, low monoamines, and thereby affecting the response of antidepressants. There are genetic factors, non-genetic factors that can affect this pathway. And because our topic is more genetic in nature, let's focus on genetic factors first. Most common one is polymorphism of this gene that encodes for MTHFR. And there are two polymorphisms that we will talk about, C677T and A1298C. Out of these two, the first one is more common, C677T. And this polymorphism is not only common, but it has shown to reduce the enzyme activity more than the other one. Studies have shown close to 40% reduction in MTHFR enzyme activity by this polymorphism. And there was one study that compared this polymorphism C677T with A1298C. And they actually not only looked at the reduction of enzyme activity, but also increase in homocysteine levels, hyperhomocystinemia, because MTHFR is also responsible for conversion of homocysteine to methionine. So if the enzyme is not working, homocysteine will not be getting converted into methionine, so a person will have hyperhomocystinemia. So what they found is that hyperhomocystinemia, high homocysteine levels were found with C677T polymorphism. But the interesting thing is A1298C was not associated with high homocysteine level, which points to less reduction in MTHFR activity with A1298C polymorphism. Okay. When you order a genetic test on a person to look at polymorphism of this gene, you will get these genotypes. A person can be either homozygous to T allele, so TT, or it can be heterozygous to, which is TC, or it can be homozygous to C allele, so CC. A person with TT and TC alleles or genotype carries an increased risk of depression compared to CC allele. And studies done on C677T polymorphism itself shows that a person with this polymorphism have increased risk of depression, and this is more prevalent in Asians, and they were not able to find this association in elderly though. But again, I will say the studies are not consistently showing same results. Moving forward to second polymorphism, which is A1298C. Not much information here, but same way, this have three options that will show up on genetic testing: AA, AC, and CC. Here, AA is the one with high risk of depression and less risk of remission with antidepressant trials. Okay. So, going with which patients are high risk? Genetically speaking, studies have found Hispanics and Mediterranean populations have decreased levels of MTHFR, and the second genetic risk is what we just talked about. A person with this polymorphism, C677T, and having either homozygous to T allele, which is TT, or a heterozygous carrier, which is TC, are at high risk. So in these cases, supplementing with L-Methylfolate will make more sense. But what are the non-genetic factors? Or which patient should you have high suspicion for folate deficiency? And these are patients with alcoholism, pregnancy, eating disorders, gastrointestinal disorders. Again, I will go back to what I said initially. Folate metabolism is linked with many other cycles. Like we talked about the homocysteine one. There is also interaction or role of B12 here in folate metabolism. Some studies have shown B12 deficiency affects folate metabolism. I'm assuming some factors do play a role in these populations also. But be cautious when you see this comorbidities for folate deficiency. Okay. For our core subscribers, I will highly recommend what we just talked about there. These are summarized in our chapter number 9.13, where we talked about major depressive disorder augmentations with L-Methylfolate. And this chapter will tell you when to augment L-Methylfolate, what are the high-risk population, and it will also talk about what medications can interfere with conversion of folate to L-Methylfolate. So role-off drug interaction also comes into picture, and what dose of L-Methylfolate to use. And we have a full section here on other augmentation strategy for major depressive disorder. Please go and read that. It will be very helpful. But moving forward with our chapter now. So we talked about polymorphism of the gene. We talked about what are the genetic and non-genetic risk factors or high-risk populations. What lab work will you do? Let's say you suspect somebody may have this. And I never recommend someone going directly to genetic testing, but I will recommend moving forward with lab work first. The most important one is RBC folate levels. Not serum folate level, but RBC folate levels. Individuals with low RBC folates are shown to have 6 times more likely to be a non-responder to antidepressant treatment. And not only that, they are less likely to achieve and maintain remission compared to those with normal RBC folate levels. And the other lab that you can do is homocysteine level, which will show you high homocysteine level as we talked about. But I will recommend staying with RBC folate level as your lab work of choice if you suspect this. Now, moving forward, let's say you did this. There is low RBC folate level. You suspect low folate levels. Maybe you have genetic testing. You have the polymorphism and all the data available. And you decided to move forward and treat the person. You will use L-Methylfolate in that case. And this circle one is L-Methylfolate, 5-methylene tetrahydrofolate. So as you can see, this diagram makes all sense right now. You supplement that, which was the last step in folate metabolism. You bypass that cycle where genes were not effective or enzymes were not effective, and then you activate the tryptophan hydroxylase and monoamines are forming, antidepressants are working more effectively. But what dose will you use for L-Methylfolate? It comes in 7.5, 15 milligram, 30 milligram. But before I tell you what dose to use, let me summarize an important study published in American Journal of Psychiatry in 2012, where they did a 2 multi-center sequential parallel comparison design trials. And these trials were very interesting. So the first trial had 148 patients, and they randomly assigned them to these 3 groups. First group was given L-Methylfolate at 7.5 milligram daily dose for 30 days, and for next 30 days they gave them 15 milligram of L-Methylfolate. This was the first group. Second group had placebo for 30 days and L-Methylfolate 7.5 milligram daily for next 30 days. And third group have only placebo for all 60 days. So this was trial number 1. Trial number 2 had almost half of the patient, 75 patients, and they were all given L-Methylfolate 15 milligram per day for 60 days. So you see the difference. What did the result shows? So results showed that trial 1 had no significant difference, whereas trial 2 showed 15 milligram daily dose showed significant greater efficacy compared with continuation of SSRI treatment here. And please make a note that these two trials had only SSRI treatment. They had no other antidepressant treatment. And the study also found NNT, which is the number needed to treat for response, was approximately 6 in favor of using L-Methylfolate at 15 milligram per day. And this is comparable to the results reported by other augmentation strategies in major depressive disorder, like using atypical antipsychotics and lithium. And in these studies, L-Methylfolate was well tolerated. The adverse effects were no different than those reported in placebo. And as you noted, that this study was for 60 days. So next question comes is the duration of L-Methylfolate treatment in terms of efficacy. Is there data available for longer duration of treatment? Because the studies that I found, the study showed that majority of patients may respond to adjunctive L-Methylfolate 15 milligram dose in first 3 to 6 months of therapy. But there was not much data on larger duration, but we found this study which was done for 12 months. And this was an open label study for L-Methylfolate 15 milligram adjunctive treatment with SSRI again. And the results were positive like the last study. And this study showed 15 milligram is effective, safe, tolerable, with high retention rate. So that's a positive result again. Let me summarize everything that we talked about. If you do a genetic testing, this is the enzyme, this is the polymorphism to look for, having a TT and TC polymorphism of C677T carries a high risk of depression and poor response. Same goes for the other polymorphism. AA is with A1298C polymorphism carries a higher risk. Hispanic and Mediterranean population is at high risk. If you decide to go with the lab work, RBC folate level should be the first lab work to aim for. And if you decide to treat, L-Methylfolate 15 milligram daily dosing will make more sense. I have seen in some people, very rarely, people get more anxious or irritable on 15 milligram. In those cases, going to 7.5 milligram daily will make more sense. Okay. So thank you for listening this whole chapter. I'm Dr. Harvinder Singh. This is my email. Please do not hesitate in contacting me with any questions. And I will also recommend, please consider joining our course, Physician Guide for Clinical Psychiatry. This is one of the chapter in that course also. And please do not hesitate. Please post your replies below. I will open the reply section for everyone. Thank you again. See you in next podcast. Take care. Bye.